So for women, how many people then are going to require surgery? About 1 in 5 women will need surgery. But that means 1 in 4 don't, okay? So let's break down the pelvic floor disorders a little bit. We're going to talk about bladder control, we're going to talk about prolapse, and then we'll talk about some of the fecal stuff. So when we talk about bladder control, that really gets broken up into 2 main categories. We have stress urinary incontinence and we have urge urinary incontinence. And so when I say stress incontinence, patients also think it means like I'm stressed, I'm anxious, and especially post-COVID, like who doesn't have anxiety and stress, right? But that's not really what it means. What it really means is when you sneeze or when you laugh with your girlfriends, especially if you've had a glass of wine, or when you're up here doing your exercises, and Lord have mercy, no one with stress incontinence will be jumping on the trampoline, right? And this makes me laugh because one of our nurses actually got me a little sign like this. It says, "I laughed so hard the tears ran down my leg." So this is due to urethral weakness, right? So this is a musculoskeletal problem. And there are conservative treatments, right? So weight loss. So we know from a very large study that just an 8% reduction in weight can result in a 40% reduction in incontinence. For somebody that weighs 150 pounds, that's 12 pounds. That's not terrible, okay? Unless you're actually trying to do it, and yes, it's difficult. If you smoke, quit, okay? Smoking is going to double your risk for a pelvic floor disorder, all right? And then, and I'm going to shout out to our physical therapists in the room, you're talking about your pelvic floor exercises, all right? And if you'll notice on here, and I didn't even know these ladies were coming, right? So if you'll notice on here, it says with a certified physical therapist. So we're super, super lucky in Cincinnati to have physical therapists that specialize in the pelvic floor. You're not going to go to a giant open room where somebody's working on their shoulder to have your prolapse and your incontinence worked on. And it takes additional training, additional certification to be the physical therapists who work on that. And we happen to have Ava and Michelle here with us, who are 2 of our physical therapists. And women with mild or moderate leakage can actually get the greatest amount of improvement. Okay, so what are some of the surgical treatments? So when we talk about the surgeries to fix stress incontinence, there's actually several of them that we can do, but they have extremely high success rates. So a lot of times patients will come in and I'll say, we can take care of this. You know, we can do this with pelvic floor PT. We can do this with some surgical interventions. And they'll go, yeah, but does it really work, right? Nobody wants to go through a procedure if they're not going to see a good outcome. So we know that the outcomes for some of the minor outpatient procedures are around 94% success. So let's talk about urge incontinence. This is the go-go girl of the past, all right? And then this is what they turn into later because I got to go to the bathroom and I can't make it in time. Traveling feels like this, right? I am not looking for my exit to, get off to go get food. I need to go pee. Airports are a nightmare for patients who have urge incontinence. So urge incontinence is often also called overactive bladder. Think of those things synonymously. So it means urinary urgency. I got to go and anti-bar the door, get out of the way. It also means I'm trying to get in there, pull everything down and get seated, and before I can do that, the urine is coming out. It also means I got to go all the time. I just peed an hour ago. I got to go back. I didn't drink anything. I didn't have coffee. I didn't have tea. And I find myself in the bathroom again. Normal voiding, because I get this question a lot, is around 8 voids a day, okay? Getting up in the middle of the night, also common with overactive bladder. Once at night is okay. So twice or more, not normal. That's when we need to start thinking about doing something about it. So more than 517 million women visited the doctor in 2009 for overactive bladder symptoms. I mean, a ton. So what are the conservative treatments? Be diet savvy. If you come into my office and tell me that you have urgency and frequency and you drink 12 Mountain Dews a day, I'm probably going to tell you to stop drinking your Mountain Dew, right? There are certain things we know that are irritating to the bladder. Coffee, tea, soda, anything that's carbonated, they just make the bladder angry and they create more of those symptoms. I'm sorry, but again, is weight loss, right? So if we can have a normal BMI, our bladder responds better. And then back to pelvic floor PT. And then we start to talk about the things that aren't conservative, okay? Oh, I got to move this thing because this is a little picture that people recognize. So if you guys ever saw these little commercials, this little pink guy down here in the corner is actually a bladder, and he's like pulling the lady off the bus to go to the bathroom or pulling her out of her seat at the show to go to the bathroom. And it really does feel that way. Uh-oh. I think I did.
Just click on
Back here. Oh, there we go. All right. So we have oral medications, and there's a ton of them. And now there are actually some generics, which is wonderful. Okay. This whole list here can have side effects. All drugs can. Dry mouth, constipation, most common side effects. There are 2 drugs now that don't fall in that same category, Myrbetriq and Gemtesa. Those don't carry the same side effects, which is really, really nice. So when I can, I like to start with these 2 drugs. Sometimes the insurance companies won't let me, and we start with the others and then move back to the Myrbetriq and the Gemtesa. So there is a small chance of elevated blood pressure with those 2, but it's really low. All right, so now what are the procedural things for overactive bladder? Well, the first thing is what we call sacroneuromodulation, or a nerve stimulation. That's this guy that you see right here. A lot of people think of that like a pacemaker. It's made by the same company and everything. So when we think about overactive bladder, that's a nerve issue. You got to get there. The signal is happening. It shouldn't be occurring. The second thing there is called posterior tibial nerve stimulation. This little needle here is effectively an acupuncture needle, and it stimulates the nerve. And then, yes, that says Botox. It is the exact same Botox people put in their face for cosmetics, except it's in the bladder. It does the same thing, though. It's trying to get that muscle to not contract when you're not telling it to do so. Obviously, we don't inject the entire bladder because that would be bad. You couldn't pee. So just small areas within the bladder. Okay, so if we talk about incontinence, and I told you there were 2 different kinds. We know that stress incontinence affects about 50% of all those who have leakage. Urge is 14%. And then about 30 to 32% are actually going to have both. And that's the patient that comes in frustrated because no matter what I do, I'm leaking all the time. All right, so what is the bigger impact of leakage? Well, it affects all of these things. There are women who have to leave a boardroom meeting because they have to go pee every hour. There are women who won't go out with their girlfriends because they're afraid they're going to leak because this one friend makes them laugh all the time. It's emotionally draining. You're always worried about, do I have a pad? Am I going to smell like urine? Do I have a change of clothes? There are some women who don't even tell their partner, right? And then there's some women who actually have intercourse and then have leakage with intercourse. So it is a big deal because early on, women just adapt. It's what we do, right? We just deal with it, fix it, and move on. But in reality, it can lead to other issues, all right? And all the way up to the severe things like assisted living and long-term care. And I say that because it is the number one reason that people are admitted to nursing home is urinary or fecal incontinence. So, any guesses on what percentage of women with urinary incontinence say that they worry about coughing, sneezing, or even laughing in public for fear of having an accident? Guesses? 70, yes, like everybody, right? The only people who don't fit in there are like the 15-year-olds, right? Like, all right. 35% avoid exercise. I would say when I talk to patients, I think it's a lot higher than this. This was out of a population study. I would say that a large percentage of people, will either avoid travel or do it in specific ways, right? This is the part that hurts me. 62% of women wait a year or longer before they even bring it up, right? Not that they seek treatment, but before they even bring it up. And then 17% will actually wait almost half a decade. All right, so why do we do all of these things? Well, we're embarrassed about it. It's not like you go out to dinner and say, oh my God, that joke was hilarious, I just peed my pants, right? A lot of women don't know there's anything they can do about it. I cannot begin to tell you the number of times that a patient has said, well, I told my doctor and they just told me it was normal. It was part of getting older, right? There's also this false perception that the treatments don't work, right? Or that they don't last very long. And then as women, this is what we do. Everybody else comes first. My job, my husband, my kids, my patients, the neighbor, the store clerk, and then I take care of me, okay? So we're going to move out of the bladder control stuff, and then we're going to move on to prolapse. We'll come back at the end, and I'll let you guys ask whatever questions you might have. So prolapse really just means loss of support, all right? So if this is sort of a cross-section through the middle and just looking at everything from the side, this is normal anatomy. So prolapse is often described as patients as sagging, dropping, bulging, feeling like something is fallen. They'll also say that they feel like if they have a tampon in, like it's falling out. The most common thing that I hear from patients is my bladder fell. That's actually a cystocele. It's actually a loss of support of the vaginal wall. And then beyond that, the bladder falls down behind it. There's also a rectocele, all right? This is different than rectal prolapse. This is also a problem with support of the vaginal wall on the posterior side. Patients with this will often complain of feeling like they have a bulge, especially if they're having constipation. They have to push the bulge in order to start a bowel movement or finish a bowel movement. And then the uterus itself can also fall down, right? So the uterus should be way up at the very tip top of the vagina, and it literally can come all the way down, okay? So there are treatments that are non-surgical. Anybody know what these, and you guys can't answer. Anybody know what these white things are over there? Some people will say a diaphragm, things like that. It's actually a pessary. And so these actually, for women who don't want surgery or don't want surgery right now, or want to try everything conservative, pessaries can work. We can actually fit about 75% of women with a pessary. It goes in the vagina, holds everything in place. It doesn't fix the prolapse, but it lets you live your life without all of the problems of the bulge. Surgery can be a lot of different ways: vaginal, laparoscopic, robotic, all of those things. So this is I think an important point to take home is it's really, really, really common. If you or your sister or your mom have any of these things, they're not alone, right? So remember I said PFDs was going to come up again, so it's down there on the bottom. 50% of women have some type of prolapse. 1 in 3 then of women are affected by pelvic floor disorders. All right, so if we look at the data on surgery, the lifetime risk we talked about is 1 in 5, right? So about 20%. So effectively, 1 in 5 women are going to have surgery. And it really just highlights how super common this is, despite the fact that I think it's really under-recognized and under-treated. Women just deal with it. It's what we do. So what caused this in the first place? I get this question a lot. Well, this is one of the things, right? This is actually my firstborn right here. That is not me. I'm not that tall or that skinny. But this is one of the biggest things. And so when you talk about deliveries, you talk about big babies, difficult deliveries, operative deliveries like a forceps or a vacuum, lacerations at time of deliveries, or just long labors. All of those things have an impact. Also being menopausal. We know that there is, a bimodal rise in these conditions, and that second peak happens after menopause. Part of it is our connective tissue. It's just how we're made. It's our DNA. It's part of our makeup. So you don't have to have any kids at all, be premenopausal, and you can still have prolapse or stress incontinence. And then lastly, as I said before, smoking. That's a huge risk factor for all of these things. I can't think of a single thing that smoking is good for. And then jobs that have chronic heavy lifting. So people who work in factories that are always picking up 50, 60 pounds of things, those people are at increased risk for these things. So can we really fix prolapse? What we know is 90% of patients who seek care report a significant improvement in their symptoms. Not like, yeah, it's kind of better, but heck yeah, I'm much, much better. So there's a wide array of treatments. So we talked about don't drink the things that you shouldn't drink, no coffee, tea, soda, or limit it, right? You need to have your 1 cup of coffee in the morning? Fine, don't follow that with 8 glasses of tea. Pelvic floor PT, again, we have a lot of options in Cincinnati, which is way better than some whole states. There are medications, especially for the urgency and the urgent continence, pessaries for prolapse, bladder treatments such as Botox, the pacemaker for the bladder, which is called sacroneuromodulation, and then obviously surgical options. And to be quite honest, I can't tell you the last time I did a surgery that wasn't minimally invasive. Patients go home the same day. It's not, the surgeries of old that are stem to stern. All right, so fact or fiction. Surgery requires big incisions on my belly. Not anymore, right? It used to. It really did. But now you're looking at little teeny tiny incisions and sometimes no incisions on your belly at all. And that's the reason most people send their patients to me as a urogyn is I can do all of these things through the vagina. I don't even have to risk bowel injury by doing anything to your belly. So fact or fiction, surgery requires a lengthy hospital stay. Oh, that's me. Would you mind just silencing that? Sorry. That's the Rocky Top coming out. And so we just talked about that. Absolutely not. So most patients get to go home the same day. Now, don't get me wrong. I look at every patient, and if I think the patient needs to stay overnight for health reasons or monitoring, I'm going to keep you overnight. But about 98% of patients are going to go home the same day. So fact or fiction, surgery takes a long recovery, right? That's not really true. That's the point. I want to get our women in our population back to living their life, doing the things that they love, running, going to the market, whatever they need to do, working even, okay? So 1 in 3 women will experience a pelvic floor disorder in their life. That's true. Surgery is the only way to fix pelvic floor disorders, and you should just wear pads. Obviously, that's not true. And this one drives me nuts. Honestly, I do hear this almost every day. Pelvic floor disorders are a normal part of aging. It happens. It occurs with aging. It doesn't have to be normal. It can be corrected. So things to remember is urinary incontinence does not have to be part of the normal aging process. Obtaining that correct diagnosis, do you have stress incontinence or do you have urge incontinence or do you have both, is so important. And when patients come in and they say, oh, well, my friend, took this medicine and it was amazing. And I go, yeah, but you have stress incontinence, so that's not going to work. We have to be open to recognize that we have to make the right diagnosis before we can do anything else. There are lots and lots of options. The right doctor is going to talk through those options with you, and you're going to come to a decision together. And then that takes an informed discussion, because what a 30-year-old, powerlifting, never had a baby female wants is going to be very different than an 80-year-old who, has mobility issues with a walker. And truly, truly, it is within control to get back an active lifestyle. So many women alter what they do every single day because of incontinence, because of prolapse, and because of urinary frequency and urgency, and it really doesn't have to be that way. So simply in conclusion, pelvic floor disorders are super common. They're very, very treatable. They can have a severe impact on so many aspects of our quality of life, and it doesn't have to be that way, right? We're very fortunate not only to have our pelvic floor PTs, but to have 3 urogyns right here in Cincinnati that are all double board certified and fellowship trained. And then seek advice, ask questions, and talk to other women around you, right? And educate your friends. So here's some resources for you guys just to kind of think about if you needed to gather more information. You can obviously go to our website. This Voices for Pelvic Floor Disorders is actually run by our National Scientific Committee, which is called AUGS, the American Urogyn Society. So this is a great place to go for information. And then here lastly is the AUGS website itself. So what now? So when you go see a doctor, be sure you're seeing the right doctor, right? If you're a female with these issues, you need to see a urogynecologist. You don't just go see, you don't go to the cardiologist for your bladder. Ask questions. Ask a lot of questions. What all can we do? What's conservative? What are the best options? What's the most effective? What are the risks of complications? And then pick a treatment that's right for you, because like I said, it's not the same for everybody. And then lastly, get back to enjoying your life. Like, that's the reason that I do what I do, is when a patient comes in and they give me a hug and they go, you gave me my life back. Like, that's the greatest gift of all, right? And so now I'll take any questions. I don't know how to take questions from the chat, Jamie, so I will let you do that. You guys are welcome to ask questions. Certainly, it's one of those things that I know that what I do lends itself to sometimes not asking questions out loud. That's okay. If you have questions for our pelvic floor physical therapists, I'm sure that Michelle and Ava would answer those too. And then I'll hang around for a little while after if you want to ask questions privately.
There's just that one question on there.
What is the best exercise, walking or biking or other? You want to answer that one? Yeah. So, so the question was, what are we trying to treat? If we're talking about stress incontinence, are we talking about prolapse, or are we talking about making sure that other symptoms don't get worse? In general, walking is always good, right? I mean, I don't think that anything is going to be negatively impacted by walking. You're getting your steps in, you're getting core exercise, all of those kinds of things. If you want to let us know if there's anything more specific, we'd be happy to answer that way, unless you have any other information.
More like if it's going to induce more symptoms, maybe avoid that, but if you don't have symptoms.
Yeah, and so just in case you can't hear Michelle, you hear Michelle Koval talking. She is one of our pelvic floor physical therapists. And she was saying some of the advice that she will give is as long as it's not inducing more symptoms, it's usually okay. But if you're doing an exercise and it creates worsening symptoms, it might be something to avoid. Anybody else? All right. If you guys need anything, like I said, I'll stick around. You're welcome to give us a call. If you guys need anything, please let me know. And that is all I have. All right. Thank you very much.
Thank you.
Yeah.